This is Dr. Isabel Virella-Lowell on the behalf of Breathe Alabama and ACHIA Asthma Learning Collaborative, presenting the identification and diagnosis of asthma. These are my disclosures. At the conclusion of this Internet Enduring Material activity, you will be able to restate the definition and epidemiology of asthma, review asthma triggers and typical presentation of asthma symptoms, discuss the typical steps to making an accurate asthma diagnosis, and identify and reduce the exposure of risk factors. Asthma is a chronic inflammatory disorder of the airways mediated primarily by activated Th2 cells. These cells release different cytokines that stimulate plasma cells that produce IgE, mast cells that release histamine and prostaglandins and leukotrienes and are involved in the immediate asthma reaction, and eosinophils that release peroxidase and leukotrienes that are involved in the delayed asthma reaction. Chronic inflammation is widespread and variable in asthma and often leads to reversible airflow limitation. Asthma is also associated with airway hyperresponsiveness. The inflammation and hyperresponsiveness seen in asthma lead to recurrent episodes of wheezing, breathlessness, chest tightness, and coughing. As can be seen in this cartoon, the asthmatic airway, as compared to the normal airway, has a much thicker airway wall. The wall is inflamed and the muscle that surrounds it is hypertrophied. During an asthma attack, the swelling gets worse, mucus production increases, and the smooth muscles that surround the airways tighten, thus trapping air in the alveoli. In asthmatics, these airways can become hyperresponsive so that even trivial amounts of triggers can cause airflow restriction. In 2015, the last survey was done by the Centers for Disease Control and Prevention to determine the prevalence of asthma. At that time, 8.4% of children had asthma. Asthma is more common in females when you take the adult and pediatric populations together. However, in pediatrics, males are more likely to have asthma than females. And asthma is more prevalent in the African American community. Again, in children, 9.9% of males have asthma versus 6.9% of females. Asthma is more common in African Americans and Puerto Ricans, and asthma is also more common in those who are in lower socioeconomic classes. The yearly cost of asthma in the United States is $56 billion. 89% of that comes from direct costs, things like medications, doctor's visits, ER visits, hospitalizations, and 11% are indirect costs, things like time missed from work or school. In children ages 5 to 7, asthma is the top reason for missed school, accounting for 10.5 million absences per year. Asthma is the third leading cause of hospital stays in children. In 2009, 1 in 5 children with asthma went to the emergency room for an exacerbation. So what predisposes children to having asthma? Well, first there's genetics. Certainly a family history of asthma or atopy makes a child more likely to develop asthma. There are environmental factors as well, such as pollutants and allergens that contribute to the development of asthma. And obesity is also known to contribute to the development of asthma. The hygiene hypothesis has also been proposed as a reason for the increased prevalence of asthma. The hygiene hypothesis states that exposure to more germs early on favors the stimulation of the Th1 response. So children who are from large families, live in rural versus urban areas, have older siblings, are in daycare, or have frequent infections are less likely to develop asthma. In areas where parents are more protective of their children and they have less exposure to infection, children are more likely to have a greater Th2 response, which predisposes to the development of asthma. Asthma has a great number of triggers. There are inflammatory factors like respiratory infections, substances at work, and allergens. There are irritants like temperature changes, exercise, exposure to cold air, stress and emotions, and strong odors. And then there's tobacco exposure, gastroesophageal reflux, pollutants in the air, and food additives and medications such as NSAIDs. Some of these triggers we can counsel patients on avoidance. Things such as allergens, certain medications, food additives, and tobacco exposure and strong odors. Others we can treat, like gastroesophageal reflux. All of these triggers cause symptoms such as coughing, wheezing, chest tightness, and dyspnea. Typically, an asthmatic will present with recurrent episodes of wheezing, a chronic or recurrent cough that is worse at night, cough or wheeze with exercise, chest pain, colds that go to the chest or take greater than 10 days to clear. Parents usually give a very clear-cut history of a cold lasting 2 weeks, but when questioned, it's just the cough that's persisting that long. They have worsening symptoms with infection, allergies, irritants, strong emotions, menses, and changes in the weather, and they can have perceived breathing changes. Asthma creates a great burden for the patients impacted by it. Their lives are affected by the prevalence of their cough, the discomfort that the asthma causes, the limitation in activities caused by their asthma, mood problems resulting from being sick, disturbed sleep, social isolation, and missed school. So making the diagnosis of asthma is important. To make this diagnosis, you need to evaluate the history of the patient and the pattern of symptoms. Ideally, you'd like to measure lung function in patients 6 or older. This can be done with spirometry. The flow loop changes on spirometry, or FEV1, should be reversible. A normal FEV1 is greater than 80. If the FEV1 is below 80 or even above 80 and improves by 12% following a bronchodilator, that's characteristic of asthma. An FEV1 FVC ratio of less than 80 is also a very sensitive marker of asthma. If spirometry is inconclusive, other tests are available, such as exercise challenges or methacholine and histamine challenges. In children with asthma, it's also important to measure their allergic status so you can identify risk factors and counsel on avoidance. A chest X-ray is also important to exclude other diagnoses. This is a typical spirometric tracing. In this tracing, the blue line is the pre-bronchodilator flow, and the red line is the post-bronchodilator flow. You can see that the blue line looks a little scooped in the middle. It is a little concave, and this is typical of asthma. In post-bronchodilator, that the curve changes in shape and increases in size tremendously. This is a patient who's had a 53% increase in FEV1 following bronchodilator, which is, again, characteristic of asthma. Each FEV1 curve represents the highest of 3 repeat measurements. Children need to be able to have 3 reproducible efforts in order for the test to be judged reliable and accurate. An FEV1 FVC ratio is a more sensitive estimate of airflow limitation than FEV1 alone. So often the FEV1 FVC ratio may be the only thing that's decreased. In children, FEV1 FVC should be 85 or greater. In children who are younger, Asthma is harder to diagnose. Therefore, the Asthma Predictive Index has been developed. This is for use in children 5 years and younger, and a child can be diagnosed with asthma if they meet one major criteria or two minor criteria of the API. The major criteria being parental asthma and eczema, and the minor criteria being allergic rhinitis, eosinophilia greater than 4%, and wheezing that's not associated with upper respiratory infections. When making the diagnosis of asthma, it's important to exclude several other disease processes that can be mistaken for asthma. These include chronic sinusitis, large airway obstruction from a foreign body, vocal cord dysfunction, a vascular web or ring, airway malacia, stenosis, or compression. Allergic rhinitis. Other diseases causing small airway obstruction, such as bronchiolitis, cystic fibrosis, bronchopulmonary dysplasia, and cardiogenic pulmonary edema, and aspiration. And finally, mycoplasma infection. Often, determining whether a patient has persistent asthma or exercise-induced asthma or bronchospasm can be difficult. These are some guidelines for helping determine which your patient may have. Exercise-induced asthma consists of coughing, wheezing, chest tightness, shortness of breath, or fatigue with exercise. These symptoms usually start 15 to 20 minutes after the beginning of exercise or 5 to 10 minutes after exercise is stopped. Usually, you need to have cough or wheeze to confirm by symptoms alone. The presence of just shortness of breath or fatigue could be associated with poor conditioning and may not be related to asthma at all. If you're unable to make the diagnosis based on symptoms alone, an exercise test is available. Treatment for exercise-induced bronchospasm is pre-treatment with albuterol HFA, usually 2 to 4 puffs, 15 to 20 minutes before exercise. They should also get 4 to 6 puffs of albuterol as needed for cough or wheeze. Most patients with persistent asthma do have exercise-induced symptoms. However, they also cough during the night or during the day unrelated to exercise and when they are at baseline. If a patient describes difficulty getting air in, a throat tightness, or has a loud audible wheeze or hoarseness with their attacks, consider vocal cord dysfunction as an alternate diagnosis. The key components to managing and preventing asthma once it's been diagnosed include developing a relationship between the patient and the doctor that is a partnership, identifying and reducing exposure to risk factors, assessing, treating, and monitoring the asthma closely, following the NHLBI guidelines, and managing asthma exacerbations. In order to develop a patient-physician partnership, guidelines on asthma management should be available but adapted and adopted for local use by providers. You should have these guidelines in a place that is easy to access in your office so you can reference them when needed. There needs to be clear communication between the healthcare professional and the asthma patient. This is key to enhancing adherence to medications. Education is continuous at every visit and should include the family. Patients should be provided information about asthma, training on self-management skills, and a partnership amongst his healthcare providers, the patient, and the family should be emphasized. I often tell my patients that I will be working with them as part of their team to control their child's asthma, that their input is valuable, as are their opinions, and I make sure to listen carefully to any questions or concerns they may have. Identifying and reducing exposure to risk factors will also be important once managing asthma. It's important to reduce exposure to indoor allergens, things like dust mites and cockroaches. If a patient has a dust mite allergy, using bedding encasements is recommended, as well as washing bed linens weekly, avoiding downfillings, limiting the number of stuffed animals to those that can be washed, and reducing the humidity level in the home. Homes should be sprayed for cockroaches, and as many water and food sources as possible should be removed to avoid cockroach infestation. Children with asthma should avoid tobacco smoke. Passive tobacco smoke exposure is known to trigger asthma and make asthma difficult to control. Children with asthma should avoid vehicle emissions. Irritants in the home and school should be identified and removed if possible. Things from strong cleaners or air fresheners to eliminating mold. All those will help control asthma exacerbations. Finally, we need to recognize the role of infections on asthma development, especially in children and young infants. And a flu vaccine is recommended annually for all asthmatics. The benefit of home visits cannot be stressed enough. Having someone visit a patient's home and identify potential triggers and provide education or resources to reduce or eliminate exposure to triggers is invaluable. Asthma can be effectively controlled in most patients by intervening to suppress and reverse inflammation, as well as treating the bronchoconstriction and related symptoms.